This is part 2 of musculoskeletal neuromuscular disorders, and we're on myelomeningocele. And most of these kids will have hydrocephalus, 80 to 90%, and they'll need that ventricular peritoneal shunt that we talked about in the intracranial pressure chapter. So most of these are in the lumbar or lumbar sacral area. What is affected depends on what nerves are part of that, but most of the time it's going to be the lower extremities, the bladder, and the bowels. So you can also see joint deformities, and it's not necessarily equal side to side. Usually both sides are impaired, but you may have one more than the other. And these kids, they need a multidisciplinary approach because they do have many different issues. So prevention is our folic acid supplements. And if there's been a history of a neurotube defect in the family, or that this mom's had a previous child with a neurotube defect, we're going to go even higher on her daily folic acid. And we really want to start this before she becomes pregnant. In fact, the recommendation is that all women of childbearing age take folic acid, because they say, somewhere between a quarter and a third of pregnancies are not planned, and this is developing in utero right about the time mom figures out she might be pregnant. So by the time she's sure she's pregnant, it can be too late. So one of the problems they have is genital urinary dysfunction. They don't have urinary continence. They can't really bear down. They can't feel when they need to go. So that causes problems with UTIs. We like them to do in and out catheterizations to empty that bladder. That's pretty hard, particularly for a female, and when your legs don't work all that well. So over time, often they'll choose, as selective, but they'll choose to do a metrophenol, and that's what that picture is there. They make a connection to the bladder from the abdomen, and usually they do at or very close to the umbilicus, and so it makes it easy for the person to self-cath themselves. For bowel control, we're going to start just trying to make sure that their diet is good, that they have enough fiber to form good stools, and see if we can get them on a regular bowel pattern using laxatives, suppositories, enemas if needed. But often they'll end up choosing to do this antegrade continence enema. It's sort of like the metrophenol. You make an opening on the abdomen to do the enema through. They can use the appendix or a little plastic piece, and then just like usual, just like other people, every day or every other day, depending on how their body seems to work, they figure out what works for them and they do their enema. And this is an antegrade enema, so they're going to instill the enema here, and it's going to go through the large intestine and out the rectum, right? When we give a enema, we go retrograde because we start at the end instead of at the beginning. So this one's the chate, where it's a little plastic piece. If they took the appendix that hangs off here and brought it up to the surface, that's the malone, but it's the same idea. With these kids, we're really worried about latex allergy. They get exposed to so much latex, they have a high risk for latex allergy. So latex allergy increases the more latex you come in contact with, especially your mucous membranes, your wet skin, into the bloodstream or the airway. And a latex allergy is one of those allergies that can be an anaphylactic reaction. There are some foods that seem to have a cross reactivity with latex. That's bananas, avocados, kiwis, chestnuts. So warn your patient about that. But our goal is to prevent these kids from getting a latex allergy. So we just say they have one before that develops, and we will use all latex-free products on them to prevent that allergy from happening. And if it does happen, because this can be anaphylactic, we need to make sure they really have a latex-free environment. Okay, moving on. Limb deficiencies or polydactyly. So you can be missing a part or all of a limb. Usually this happens because of a teratogenic exposure in the first trimester of pregnancy, a medication, or an illness that mom had. It can also happen from an amniotic band, so a piece of scar tissue is floating around in there, gets twisted around the extremity, prevents it from growing. There's really nothing we can do to make, if the extremity is not there, we can't make it be there, but we can help the child to learn ways to do things without using that extremity, and we can help them get a prosthetic and learn how to use their prosthetic. Polydactyly is an extra digit, and we usually take these off surgically, and if you look at those toes, there's too many of them. Sometimes polydactyly goes with other anomalies, and sometimes it's just by itself, but it's worth looking. Are there other problems? Congenital clubfoot, this is a foot that's turned in, and what we usually do is serial casting. So about every week they'll push the feet as far as they can and cast them, and then the next week push them as far as they can and cast them. Sometimes the tendons are so tight that they have to do surgery to release the tendons, but usually 6 to 10 weeks they can get the feet where they want them, and then we'll have the child wear these sandals with the bar to keep the feet in the correct position for a while. And kids, they can learn to walk and crawl and everything in this. It's amazing. Things don't slow them down one bit. Osteogenesis imperfecta, often called brittle bone disease. This is a hereditary disorder, so it's a passed down, but they say it's not a perfect autosomal dominant recessive reactivity. So there's some variation to it, but there is an autosomal dominant form, and this is the most common and also the most mild. Then there's an autosomal recessive, which is very severe. So what happens is the child doesn't produce collagen to make the structure, to make nice strong bones. So they're also going to have weak joints, and bluish sclera, the white of the eye, gets a blue tint to it. They're going to get fractures, osteoporosis, skeletal deformities. By the time they get to puberty, we see less fractures happening. And here's a couple of videos if you want to watch of a couple of girls talking about what it is like to live with osteogenesis imperfecta. Developmental dysplasia of the hip. We used to call this congenital dislocated hip, but not all of them are fully dislocated. So now we prefer developmental dysplasia, and you can see that right hip is not where it should be. And if you look at the pelvis here, see how kind of round that is and how not round that is, because the bone's up here instead of down here. So the hip joint doesn't develop normally because that ball of the femur is not where it should be. So some things that contribute to this, probably maternal hormones that make the maternal pelvis loose to be able to birth the baby, also make the fetal joints very loose. And then if you have a firstborn female breech, that's our biggest risk factors. They're breached, the hips are being held wrong. Firstborn, that uterus is a little tighter. Female, it's the shape of the pelvis. And then if you add in minimal amniotic fluid and a large fetus, we've really got the possibility of it happening. It does tend to run in families as well. So the treatment, the earlier we start treatment, the better. If we start treatment before 6 months, between birth and 6 months, they use a harness, and that has a really good outcome. If we don't start it till somewhere between 6 and 24 months, they're going to put this baby into a spica cast, try and get the hips aligned, which is a lot more, difficult for the child. If we wait till they're even older than that, we're going to have to do surgery, and we're never going to have as good of an outcome. The earlier we start treatment, the less invasive the treatment and the better the outcome. So here's this Pavlik harness that's used to keep the hips where we want them, in place, adducted and a little anterior. And if they're there and the pelvis is growing and the femur is growing, you end up with a pretty much perfect hip. It grows normally. You just got to be careful of the skin underneath this. Make sure that, it doesn't get irritated, but you can hold and do everything with your baby just normally. What we're looking for in the diagnostic is unequal gluteal folds. You can see that. You've probably seen this done. Listening for the hip click. You put the hips through their full range of motion and you're listening to see if the hip is popping in and out of the socket, or if it doesn't have full range of motion. And if you have them stand on the hip, you'll see that they don't stand normally. Okay, so moving on to acquired neuromuscular disorders, we'll look at CP. Some of these you're going to do in adults, but anyway, so we'll move on to acquired disorders, starting with muscular dystrophy. This is a large group of muscular diseases in children. It is genetic. What happens is the muscle fibers are kind of replaced with fatty tissue, so you get progressive weakness and progressive muscle wasting, increasing disability, increasing deformity, decreasing strength. The most common one is Duchenne's, and this is X-linked, which means it's almost exclusively males who have it. The mother's the carrier. Mother has two X's, right? So she has one affected X, one normal. She's going to give half her sons the normal X. She's going to give half them the affected X. The male who gets that bad X has Duchenne's. Her daughters, because they get another X, her daughters, half of them will not be carriers, half of them will be carriers. And then of her sons, half will have the disorder and half will not. These are the muscle groups that are affected by it. It's bilateral. It's not just one side, and it's progressive. Typically, by 3 years, there's noticeable muscle weakness, abnormal gait. The muscles enlarge, but it's because they're being replaced with fatty infiltrates, and this just continues to progress. Usually by 12, they can no longer ambulate. They're wheelchair bound, and then they usually die. It used to be late teens, early 20s. I think we're keeping these kids alive to more the mid-20s, but that's because we're putting them on CPAP, we're putting in trachs and ventilators. They're cognitively no impairment, but they have no ability to move any of their muscles. So they usually die from respiratory failure or cardiac failure. And there is kind of a typical way these kids with Duchenne's will kind of walk up their body to standing. They push themselves up and then walk up. So the therapeutic management, well, there is nothing we can do to treat it. So our goal is just to keep them as functional as long as possible. Keep them as active as we can, as long as possible. So range of motion, bracing, trying to keep them doing those activities of daily living. If they get contractures, maybe releasing those shortening tendons can help. And then genetic counseling for the family, because this is, this family feels horrible. Mom gave this disorder, her genes had this disorder. So they really need support and genetic counseling. Spinal muscular atrophy, this is another horrible one. This has several different types. At Children's you might see, usually we see this most severe one. These kids don't live past 2. It's the same sort of thing that where this is autosomal recessive, so both parents are carriers of this. The child seems normal at first, and then they start regressing on movement. Their eyes are bright, their facial expressions are bright, and they can't move their bodies, and they usually die from respiratory failure by the age of 2. But intellectually they're normal. They learn to respond to the things you say to them because intellectually there's no problems.